Thank you, Dr. Rao Ivatury, for talking to us today about thoracoabdominal trauma and particularly penetrating trauma. Can you tell us what have been the major changes in the management of penetrating trauma over the last 10 or 20 years?
Yes, one of the major changes that occurred is that luckily penetrating trauma is not as common as it used to be back in the 80s. We don't know exactly what the reason is, but especially civilian gunshot wounds, which causes the penetrating trauma, has really gone down in frequency, which is good. But on the other hand, the interpersonal violence with stab wounds and knife wounds, etc., will carry on. Unfortunately, that is not decreasing any, especially in some of the underdeveloped countries and low and middle income countries. The trauma has changed in such a way that nowadays we go more in terms of what the patient's general condition is, how stable the patient is before we treat all the injuries completely. In other words, we pay attention to what the patient's physiologic status is and try to do as much or as little as possible to stabilize this.
So moving away from some traditional rules about this type of injury requires an exploration, and this type of injury requires an exploration. Moving away from that old paradigm.
Yes, yes, moving away from that, and not all patients require exploration, because negative explorations have their own morbidity. So we try to focus on whether the patient needs an exploration, number one, and number two, what exactly does he need right now to stabilize him. We are not trying to do complete operations, but we are trying to stabilize a patient, stop the bleeding, and there's the most emphasis: stop the bleeding and stop the contamination of intestinal contents, such as if you have injuries to the intestines in the abdomen, and just bring the patient back another day. These are the so-called damage control operations.
Right.
So you do a staged operations so that the patients have much better chance of survival.
Okay. What about in the diagnostics and the assessment of injuries? How has that changed over time?
Well, now we have more diagnostics available to us. We have ultrasound examinations. We have very sophisticated, very fast, rapid sequence computerized tomographic scans, which will allow us to look at a fine detail of all the internal structures in the body. We also have visual techniques such as the minimally invasive laparoscopic techniques, by which we can put in a scope into the cavities of the abdomen and look for any kind of injuries that are there or not. So we can select the patients out for operations.
Okay. And how about if you can describe that shift about the former tendency to operate more, and we're moving away from the tendency to operate. What are the guidelines now for when to operate on a patient, say, with a stab wound to the abdomen?
So the stab wound to the abdomen, the patients may always not require an operation. They may just require observation periods to see if they require a complete abdominal exploration. So this we do by serial observations, by doing some tests such as the computerized tomographic scans, and make sure that the patient will have an exploration only if necessary, and only if it needs control of intra-abdominal structures.
Okay.
And this the same is true for even gunshot wounds in the abdomen.
Now, does the CT scan, will that lead you to an operation, for example, if you see free air or you suspect a lot of intra-abdominal bleeding despite normal hemodynamics?
That's exactly right. So if you see free air possibly coming from a perforation of the intestines, or if you see a lot of blood within the abdomen, that is concerning, or if there is a high suspicion of injury to the internal organs, then that would be an indication to explore.
Okay. And how about shock and the transfusion threshold these days? That was sort of changing during my training. Is there a strict threshold now for hemoglobin level for when to transfuse a patient who's bleeding?
Yes, I think we need to talk about patients who are unstable and patients who are stable.
Mm-hmm.
So patients who are unstable are patients whose blood pressure is very low, who have a very high heart rate, who are suggesting all kinds of internal bleeding signs. So those are the kind of patients. The, the present paradigm is not to give them too much fluids, because by giving too much fluids, we raise the blood pressure and actually increase the bleeding. But the current paradigm is to take these patients immediately to the operating room, find the bleeding spots, control the bleeding, and then resuscitate these patients.
Okay.
That's the present paradigm.
Okay.
Now, for stable patients, we are letting them hemoglobins go down to the 6 and 7 level only if they continue to fall or if they add to bleeding. Only under those circumstances will give them blood transfusions. Otherwise, we think that the body can accommodate to these low hemoglobins and gradually build the hemoglobin itself.
Okay. And how about the use of other blood products? For example, do you use FFP before you see signs of pathological bleeding? Has there been a shift in how the blood products are used besides packed
Yes,
cells?
I think that is the major change that has occurred to us within the last 10 years or so, mostly due to the information gathered from the Iraq and Afghanistan wars, where they actually showed that patients with major injuries already have a problem clotting blood by the time they come to the emergency department. And they also clearly showed that these are the patients who would require lot of blood packed cells, up to 20-30 units, before they actually survive. So the patients come in with a bleeding problem, come in with a problem in clotting blood. So these patients, we learned, is that not only do they need blood right away, but they also need the clotting factors that can be supplied by the fresh frozen plasma or the platelet transfusions.
Mm-hmm.
If you, unfortunately, we do not have fresh whole blood that patients can receive. It is impossible to get that. If you can get fresh whole blood, that is the ideal solution.
So we're creating whole blood from its components to give to patients.
Exactly right.
Okay. So what else have we learned from the experiences in our recent wars?
It's interesting that the most recent wars, the people, unfortunately, the soldiers are not dying from truncal injuries because the trunk, the chest, the abdomen is completely protected by their shields. But unfortunately, there are areas in the extremities that are exposed. And the type of injuries are not the conventional gunshot wounds that we used to see, but the explosive landmines that these army battalions suffer from. So there is a lot of extensive damage to the limbs, soft tissues of the limbs, muscles, destruction. Because of this, there is a tremendous amount of blood loss and a major amount of tissue destruction, which causes a lot of abnormal physiology in these soldiers. So unfortunately, these soldiers are losing a lot of limbs and requiring multiple operations to control this destruction of soft tissues of the extremities.
Yeah, so relatively few penetrating injuries compared to previous military engagements.
Exactly.
All right. Okay. So what else would you like to say about changes in trauma management over the past short time?
Well, the trauma management continues to be exciting because these are injuries that you can easily identify, and most of our patients are young patients. So if you do all the right things very promptly, they nicely respond to your treatment. So that is the important thing. Unfortunately, as we said, the injuries are getting more and more frequent, more and more complex because of extensive traffic crashes, etc., in the civilian population, as well as in the massive soft tissue destruction in the battlefield. Because of these people require a lot of physiologic management in terms of rehabilitation, in terms of exercises, physiological exercises. So that requires a lot of infrastructure. Most of our trauma centers are providing. Unfortunately, some of the lower middle income countries do not have yet all these facilities. So it is becoming more and more complex. Unfortunately, it is not becoming more and more successful in most of the other countries. And I think some of the well-developed countries have begun to reduce the prevalence of injuries because of very strict drink and drive laws, etc. Unfortunately, these kind of injury prevention activities are not as frequent in the low and middle income countries. So I think that's another area that should be focused on in the future.
Interesting. Great. Well, thank you very much, Dr. Ivatury, for taking the time to talk to us today. And I hope we can talk again soon.
Well, thank you very much for having me.
You're welcome.
Thank you. Bye-bye.
Thanks for checking out the Op Report. Help us keep conversations alive on topics in general surgery. Check out more episodes of the Op Report and other OnSurge content here at YouTube. Find us at Facebook. Follow us on Twitter. And find our homepage at onsurge.com. Join the conversation and tell us what topics you'd like to hear about and what people you'd like to hear from.